Good evening, aspirants. Good evening, ma'am. Ma'am, shall we start the session?
Yeah. I'm not. I'm just sharing my screen.
Sure, ma'am. So, good evening, all the aspirants. The topic for today is endocrine. It is a CBH session. Our speaker is Dr. Shraddha Patharkar, who is the associate at ABMH Pune. Thank you. Ma'am, you may take over.
We'll start with the case directly. So, 55-year-old male, 80 kgs, who stays alone. So, history couldn't be elicited. Brought to ER department in unconscious state by his neighbor. On examination at ER, he is hypothermic, heart rate of 50 per minute, BP of 90/60. Saturation is 80% on room air, so started on NRBM mask. He is E2M3B1, pupils were 3 briskly reacting to light, is barely arousable to DPS, deep painful stimulus. For airway protection, he got intubated, and the BSL was checked. It was 100 milligram per DL, and urine toxicology was sent. So ABG was done on NRBM mask. pH of 7.22, PO2 is 413, PaCO2 is 95, bicarb of 38, sodium is 125. What labs will you order to diagnose this case, and how will you manage this case?
Slide is not moving. The slide is not showing anything.
Uh, can you see these slides now? Because I'm
X-ray
sharing
only.
the
X-ray only is showing.
X-ray.
Yes, ma'am.
Yes. Now came. Yes, but make it in slide show button. Yes.
Yeah.
Yes.
Uh,
Okay.
Okay. Can you see now? Can you see this?
Still, it's in the edit button, not in the
ma'am,
slideshow.
put the screen in the slideshow mode. It is
Yeah,
near
ma'am. I've done
animation.
that only. Yeah. I've done that. Now again, I am exiting. This is escape.
Ma'am, I think that we are facing some technical issue. Actually, the screen is not visible in the slideshow mode in the session.
Yeah.
Ma'am, can you
To
again
me,
restate?
actually, to me, it's in the slide show mode only.
Okay, no problem. Can make zoom.
Can you see this now?
Yes, now clear. Better. بس decrease size. Yes, better.
So can you read the case now? Are you able to read this case?
Yes.
Yeah. So he is 55-year-old obese, staying on alone in. So history cannot be elicited. He he was brought unconscious by his neighbor, and at ER he is hypothermic, bradycardia, BP is on a lower side, saturation of 80% on room air, so NRBM was started. GCS is low, less than 8. Pupils were 3 briskly reacting to light, both barely arousable to DPS. For airway protection, he got intubated and the sugars were 100. Urine toxicology was sent. And this is the ABG. Can you read this ABG? What is the abnormality here?
Respiratory acidosis, metabolic compensatory metabolic alkalosis with
Hyponatremia.
and oxygenation seems fine.
Fine. Yes.
With
So
hyponatremia.
from the history, what can be the reason for his unconsciousness?
Mixed edema, comma.
What are the DD's differentials?
Uh, uh, Sorry to interrupt. Please, Dr. Anu, sir, please mute your mic.
Sorry. Can anybody tell me what are the differentials for this case from the history and the ABG?
Mixed
Mixed
edema,
edema, comma.
comma, hypothermia,
Okay.
hello,
Yeah.
acute intoxication, alcohol
Yes.
intoxication,
Very good. Yes.
Stroke, cerebral vascular accident.
Yeah, we don't know the history. It might be a known case of COPD also.
acute
But here the
exacerbation of
yeah, but the pH is compensated. So if it's a long standing, then this bicarb could have been higher. So even hypoglycemia. Anything else?
sugars are normal, ma'am.
Poisoning. Drug overdose.
Can it be seizure or any structural abnormality, brain structural abnormality?
Neuromuscular
Hyponatremia.
disease.
Though hyponatremia doesn't, this 125 of sodium will not cause this much of a problem, but if its baseline sodium, if at all, is 140 and suddenly it was brought down to 125 because of maybe beer potomania or something else. So you need to rule out both the structural and metabolic causes here, because we know this is the endocrine session, but in exams the case will be random. So you need to rule out metabolic common causes in this. Even for that matter, the starvation ketosis and alcoholic ketoacidosis. But again, it's not metabolic, so it can. You need to see whether it is a mixed disorder. So what labs will you order if this is a mixed edema coma?
T3, T4, TSH.
Okay.
In addition to the routine complete blood count, liver function test, kidney function test, procalcitonin, tropi,
Okay.
proBNP.
ACTH.
Even if the vignette shows AKI, then even serum CPK, because they do have proximal myopathies. So if AKI, that can be one of the differentials. Anything else? Because our next slide will be pertinent to that. Routine ECG, chest X-ray, all these things are also needed.
Urine, sodium, urine osmolality to rule
Yes,
out
yes,
hyponatremia.
yes. So what kind of a hyponatremia these patients have? Like euvolumic, hypovolumic?
Euvolemic hyponatremia.
Hypovolemic.
Yes. And in this patient, you need to do serum cortisol levels also, because associated adrenal insufficiency is also common. So our next, the how will you manage this case?
I will intubate this patient, ma'am.
Yes, you need to utter airway breathing circulation, ABC, for each and every case. Just
I will do manual inline stabilization, and I'm not sure about cervical spine also. Might be injured because the patient is unconscious.
yes,
So I
okay.
would like to intubate, first do suction and secure the airway with the help of a cuffed endotracheal tube. And then I will
Yes, this patient.
actively warm the patient.
Okay,
Put in 2 large bore IV cannula to give some fluids. Patient is hypotensive, maybe hypoperfused also because of hypoxemia. So I like to
but we need central warming. It's like the warmer should be towards the trunk, because already patient is
I
hypotensive.
will
Peripheral warming, it will
use targeted temperature control devices to
control uh, rewarming. You need to utter this word, controlled rewarming.
Acupuncture to the one.
And you need to start fluids because patient is hypotensive. uh, these patients patient might have vomited. We don't know the history. So taking care of a blood pressure if needed, vasopressors, because again this he might be hypothyroid or he might be having underlying undiagnosed hypothyroidism. So we need to utter about all these investigations as well as the management. So thyroxine, what dose, and we don't know the history. So first we need to see chest X-ray and ECG if he's having, and 2D echo of course bedside we do, if this patient is having any underlying coronary artery disease, because we don't know the history. So the dose of thyroxine will be different in those with the coronary artery disease and those without coronary artery disease. But what will be the thyroxine dose otherwise in patients without any coronary artery disease in myxedema coma? Thyroxine dose? Anybody? Can you hear me?
400 Mike.
Okay. So near about 300 to 400 mic CS. More than 500 you should not go for, because it may precipitate arrhythmias and congestive heart failure. Particularly if coronary artery disease, then you have to start at a lower dose, 200 to 300 mics. And you need to continue such a high dose for next 2 to 3 days, but with a 50 to 100 mics taper. And on day 5, day 6, the dose should be 1.6 mics per kg. So it comes around 100 in 60 to 70 kg. So then again you have to supplement this with these patients with the hydrocortisone also. You need to control, take care of his blood sugars also. If needed, DNS we need to start. Then same patient on evaluation on chest X-ray. This is the picture. Comment on chest X-ray and how will you manage?
Pericardial effusion, money bag appearance of the heart.
Okay. Anything else? Bilateral CP angle blunting. So
Pleural effusion.
yes, chest X-ray is showing both the pleural effusion and the pericardial effusion. So this myxedema coma patients, uh, even in labs also you need to utter lipid profile, because these patients might have deranged lipids. How will you manage this case? Will you go for pericardial tapping?
According to the case, according
Yes,
to
if
the
the
condition.
yes,
If
if
it's
you will
affecting
do
the diastolic RV diastole, it's for urgent pericardiocentesis. If not affecting, it will be conservative, and then observation should be given for the patient.
yes.
Close observation.
So yes, if the patient is showing obstructive shock on 2D echo, or if there is a this Beck's triad, patient hemodynamically unstable, in all these cases only. Otherwise, if patient is a known hypothyroid, many a times this is a very gradual, the fluid gets accumulated gradually. So in such cases, we may not need to tap it. So again, you need to know the precipitating factors. Infections commonest hai. Then metabolic abnormalities, acidosis itself, even raised PCO2 can precipitate it. Cold temperature, various drugs, sedative, hypnotics, then burns, trauma. All of these are the precipitating factors. You need to know hypothermia management. Okay, that also you need to read thoroughly. Again, compensated and decompensated hypothyroidism. So when CNS is involved, it means this is a decompensated state. Then we call it as a coma. So we need to know the all the differentials of coma also. So, next case is 24-year-old female got admitted in hospital with generalized weakness, body ache, complaints of nausea, loss of appetite, and decreased body weight. She had low-grade fever also and 2 to 3 episodes of vomitings. She's hypotensive, 88 by 40, hypoglycemic, 70 milligram per dl. Labs done in ward suggestive of sodium of 128, potassium of 6.5, anemia. Urea is 58, creat of 1.8, and CBC showing mild leukocytosis and eosinophilia. ABG was done. It was pH of 7.24, bicarb of 16, PaCO2 30, chloride of 110, and sodium of 127. So, can anybody enumerate the important features, abnormalities in this case? And from this case, what you are suspecting? What are the differentials, and what is the provisional diagnosis? We'll go little
Ma'am,
quickly. Yeah.
this is a young female with presenting with non-specific complaints of nausea, body ache, loss of appetite, and vomiting. Patient is hypotensive and hypoglycemic. She is also hyponatremic and hyperkalemic. Possibly there is AKI also because of rising serum creatinine. And the ABG is showing metabolic acidosis with respiratory alkalosis and hyponatremia. So this picture is suggestive of acute adrenal insufficiency.
Which are the factors in favor of adrenal insufficiency?
Non-specific complaints, hypotension, hypoglycemia, hyponatremia, hyperkalemia.
Yes, so ABG is, if you read it carefully, it is showing NAGMA, normal anion gap metabolic acidosis. Many a times you don't get time to see for the compensations and delta anion gap, but look at the chloride. And when you look at the chloride and you calculate this chloride is high, hyperchloremia is there. And if the change in anion gap is lagging behind the change in bicarb, means bicarb is much lesser than the high anion gap, it means there is associated, this acidosis can be because of something else. If it is associated with hagma, then you have to suspect nagma. This is the case of normal anion gap metabolic acidosis, and because of the aldosterone deficiency that is associated with primary or secondary, with which this is more common, aldosterone deficiency. Whether it is common with primary adrenal insufficiency or secondary.
Second.
Primary is more common.
Because you need to, in my EDIC exam, we had this question. So in lab parameters, they'll give you, you need to differentiate between primary and secondary. So see, from the history, it can be sepsis also, because there is wide pulse pressure, there is mild leukocytosis, hypotension, hypoglycemia. So in differentials, you have to utter adrenal insufficiency is because we know that this is endocrine case, but you have to utter commonest septic shock. Then you can utter adrenal insufficiency. Here the presentation is like acute abdomen. If there is a hagma plus nagma, then it can be DKA also. So all acute conditions, acute abdomen, that also in differentials you need to put. And AKI also, because AKI,
Starvation,
uremia,
ketoacidosis.
yes. So again, the primary adrenal insufficiency means when the primary cause is adrenals. When adrenals are at fault, there is a cortisol deficiency as well as the aldosterone deficiency, and that's why this electrolyte abnormality is very common in primary. That is the differentiating feature with the secondary. Secondary adrenal insufficiency means the problem is above the adrenals, either in the pituitary or hypothalamus. So aldosterone won't be a problem there. So that's why you need supplementation with fludrocort later on is needed in primary adrenal insufficiency. We'll see that later. They might show you this slide. This patient is hypotensive, and now clinical skin is showing all these changes. What you call it?
Hyperpigmentation.
Yes, very good. Hyperpigmentation again is a sign of primary adrenal insufficiency. We call it as Addison's disease. So again, in critical care, we'll get Addison's crisis, not stable chronic Addison's disease patients. But now the crisis might be they might be having underlying adrenal insufficiency, but they may have skipped their medications, steroid doses, fludrocortisone. They might have skipped it and now presented in Addisonian crisis, or it might be the first presentation, like in this case, young female presenting with hypotension, hypoglycemia, nagma, and electrolyte imbalances with discoloration. So again, this hyperpigmentation is primary adrenal insufficiency. It's not a part of secondary. So these are again differentiating features. So what is the management? Again, start with the ABC because they are having distributive shock. Start with fluids, resuscitate if needed, vasopressors. But the main important treatment here is
Steroid replace.
Steroid,
yes. And how much you'll give?
200 milligram stat.
Yes, 100 to 200 mg stat, and then you give 200 to 300 mg a day for 2 to 3 days. And in primary adrenal insufficiency, you need to shift them on prednisolone later on. But hydrocort again provides fludrocort also. So that's why when we are giving IV hydrocort, no need to supplement them with the fludrocort. Once you shift these patients on prednisone, and even 50 mg of hydrocort is sufficient to provide fludrocort. But once you shift patient on prednisone, so the equivalent dose of your hydrocort gets reduced. It becomes 20. In that case, you need to supplement them with fludrocort 50 to 100 microgram. And again, treatment of the precipitating factor is very important. Even what are the precipitating factors for adrenal crisis? Can anybody tell me what are the precipitating factors?
Usually infection or stress,
Yes, very good.
operation.
Commonest is infection. Any stressors. So it might be decay can put patient into adrenal crisis. Any stressors like burns, trauma, surgery, even the minor surgeries, even if the patients, because it's a extra stress and patient is having underlying undiagnosed adrenal insufficiency, the cortisol levels will be inadequate in the body for that stressor, and they may land up into this. Even the extremes of temperature, that can lead to adrenal crisis. So you need to know the whole list of adrenal crisis. There are certain medications like etomidate can cause adrenal insufficiency, ketoconazole can cause. Uh, so autoimmune disorders, wherever the adrenals are affected. So it might be autoimmune disorder in India, where TB is very endemic. So tuberculosis, meningococcal septicemia. So you need to know all these infections, may viruses, TB, bacteria, any of these can cause. So let's move to the next case. 32-year-old P2L2 post LFCS had atonic PPH post re-exploration and massive blood transfusion. She got mechanically ventilated post-operatively for weaning. When sedation holiday was given, patient complained of not able to see properly, and the opthal reference was given. MRI brain was done. So comment on imaging, what labs and diagnostic tests you'll run, and further management. In exam, they might not put you give you MRI films, but again for this particular case, MRI brain is important. So I mean that is the diagnostic modality. And again,
Enhanced
in
syndrome.
adrenal
That's not normal.
investigation, you have to utter CT and MRI. Okay, I forgot to tell that. CT scan of adrenals or PET scan, uh, because even the malignancy nowadays, this immune checkpoint inhibitors and all, they also put patients into adrenal insufficiency. We are using so many immunotherapies for cancer. So that is also one of the commonest precipitating factor. Okay, and in this case, the what are the history itself is very peculiar for this condition. So she is P2L2 post section. Tonic PPH means massive blood loss and massive blood transfusion. And now she has a vision problem.
Sheehan
The
syndrome,
pituitary
vertical
nephrotic
apoplexy.
Yes, very good. So because of the severe shock, hemorrhagic shock intraoperatively, there might be pituitary necrosis, apoplexy, and many a times this is like permanent, and they need to go for a lifelong hormonal replacement therapy. So that is the management plan. Again, depending upon the location of a tumor. So if it is compressing optic chiasma, there will be complete loss of vision. Sometimes just the bitemporal hemianopia can be the presentation. Again, if it is compressing your third ventricle, patient might present with hydrocephalus. So same patient presenting with seizures and dilated ventricles, then again you might need to put EVD. But the main treatment is like medical management is the hormonal replacement. So you need not need to go deeply into this, but just you need to know the basic management. Again, here the anterior pituitary hormones will be will be depleted much more than the posterior, because the anterior circulation is a low pressure circulation, so it is vulnerable for ischemia as compared to posterior. But these patients might present as DI also. So this pregnant lady, PPH, pituitary apoplexy, they in scenario they might give anterior pituitary hormone deficiency. It might be adrenal insufficiency, thyroid hormone insufficiency, or it might be posterior hormone problem like diabetes insipidus, hypernatremia, polyuria. That your case might present like that. 50-year-old male, known case of hypertension, diabetes, COPD, treated for severe CAP with septic shock on mechanical ventilation with moderate dose of noradrenaline. In view of persistent encephalopathy, along with other metabolic parameters, thyroid function test was done. So interpret the report. What test can be done to confirm the diagnosis, and what is the management?
CQ thyroid, reverse T3.
See, the history is
The sick
patient is
thyroid syndrome.
persistently encephalopathic. It might be septic encephalopathy, it might be metabolic, but we have run the tests to rule out the other causes, and this is the thyroid function test. Can anybody just, because I have
Secondary
mentioned the normal
hypothyroidism.
values also.
This is secondary hypothyroidism.
Maybe CQ thyroid.
So asthma is this one, CVA or
Yes, very good. Who said that? Sick. It's a sick thyroid syndrome. See, this is a non-thyroidal illness causing this hormonal imbalances, but actually pituitary gland is okay. So why this is happening is because body is trying to conserve like
TSH is low, doctor.
yeah, TSH might be low or TSH might be normal also. Even if there is a severe critical illness, then body tries to conserve everything. Even the metabolism slows down. So TSH release also from the pituitary slows down. So TSH might be normal or it might be low, and T4, T3 level might be normal or low. See, normal in hypothyroidism, TSH should be high or low. Primary hypothyroidism.
Hi.
Yes, TSH should be high. So whenever the TSH is normal or low, and your free T3, T4 either normal or low normal, then you have to go. What should be the next step to confirm whether it is sick thyroid?
We have to check the reverse T3.
Very good. We have to check reverse T3, because normally T3 is active hormone, T4 converts into T3 in periphery, and that out in T3, 80% is active T3 form, and only 15% is reverse T3. But whenever, because of this illness, cytokine this thing load, this conversion is affected and more reverse T3 is produced. So this is the diagnostic to again come to a conclusion. It is a sick euthyroid. So how you'll treat sick euthyroid syndrome?
We have to treat the primary pathology.
Yes. So and what about thyroxine?
No need.
No need.
No need to replace any
No
amount.
need.
Treating the
Assessment after 3
primary
months.
infection.
Yeah, very good. So here the thyroid glands basically they are normal. It's a body's compensatory response that metabolism is slowed down and it is conserving everything, but thyroids are okay, so no need to supplement. So the next case is
Zoom out, please, to show.
sorry.
Ma'am, can you explain?
Zoom out to show this case. Just zoom out.
Yeah, actually I've zoomed it. So
Ma'am, can you explain once again how TFT it is ECQ thyroid?
see normally in euthyroid, it looks like a secondary hypothyroidism. What is secondary hypothyroidism? Where the TSH will be low from pituitary, from either there is a hypothalamic always remember primary is primary gland. So whenever primary adrenal insufficiency, primary adrenal gland, primary thyroid hormone problem, primary hypothyroidism is the primary problem is thyroid gland. So thyroid is not producing. When thyroid is not producing T3 T4, there will be feedback mechanism and the TSH will be produced more from the pituitary. So primary may always by feedback mechanism your either cortisol releasing hormone or your thyroid releasing hormone, those will be high, always high. When it is low, when T3 T4 is low and TSH is also low, then it is a secondary hypothyroidism. So it can be a problem with pituitary or hypothalamus, where the releasing hormone or stimulating hormone is only not produced, and that's why thyroid is not T3 T4 is not getting produced. So are you understanding this primary and secondary part?
Yes, ma'am.
So primary is always the first the gland. The gland is not producing cortisol or aldosterone. Gland is not producing thyroid hormone, thyroxine. But the releasing and stimulating hormones by feedback mechanism will increase because they are thinking कि ये नहीं, the T3 T4 is not sufficient, so TSH will be more to compensate for that. It is the primary. And the secondary, the TSH is less, and that's why T3 T4 production is less in the body. So more or less euthyroid 6 syndrome, when the severity of the illness is very high, then TSH is low in sick euthyroid. Otherwise TSH is normal. In sick euthyroid, many of the cases you will see TSH normal, T3 T4 low or low normal. But if the illness is very severe, then TSH can be low also in sick euthyroid. It mimics like secondary hypothyroidism. But the confirmation is reverse T3. If reverse T3 is high, it is sick euthyroid. Are you understanding now?
Yes, ma'am.
The next is 50-year-old known diabetic IHD, LV dysfunction, CKD alcoholic with recent binging got admitted with diarrhea and dehydration since 2 days with decreased intake. At ER, he himself narrated the history and ABG was done, suggestive of. Can anybody read what is this ABG? What is the abnormality?
This is
High anion gap metabolic acidosis.
Okay. Anything else? All the you have to utter all the abnormalities. How is the sugar?
this is high anion gap metabolic acidosis with respiratory
hypo-
alkalosis and sugar
hypoglycemia, low sugar levels.
Lower sugar. Low sugar. You cannot
levels.
label it hypoglycemia is less than
Yes,
70.
with a low sugar levels with a high creatinine.
Yes.
With the
And
increased RFT, both urea and creatinine has increased.
okay.
His lactate is 7.5 with hyperlactemia, and ketone
Yes, the
with the
lactates are high.
ketoacidosis. With the
Acidosis is
ketoacidosis,
mm.
probably a lactic acidosis with the ketoacidosis.
Okay.
Beta hydroxybutyrate normal value we are not sure.
Normal plasma beta hydroxybutyrate is 6.5. Normal is less than 0.6.
Okay. So the
So
high
6.5.
ketones and
Yes.
lactic acid.
Yeah,
It's
and
a mix. It's a high anionic gap metabolic acidosis involving both ketoacidosis and lactic acidosis.
yes. So it can be euglycemic decay because the patient is diabetic, LV dysfunction might be on dapagliflozin. You have to give DDs also.
Yes.
And another
Starvation ketoacidosis is also possible because it's a recent binge drinking.
and another one more differential.
Alcoholic ketosis.
Yes, alcoholic ketoacidosis. Now
Ketoacidosis, starvation ketoacidosis.
yes, but this cannot be starvation ketoacidosis because the history is just since 2 days.
Okay.
So for severe ketoacidosis to occur in starvation, you need at least a week history or 5 to 7 days of history. So, and again, this beta hydroxybutyrate, it is much more in alcoholic and diabetic ketoacidosis. But here the sugar is okay. It might be euglycemic, but again, this ratio of beta hydroxybutyrate to acetoacetate, if that ratio is more than 5:1, here that ratio is 6.5. If that ratio is 5 is more than 5:1, it is alcoholic ketoacidosis. If it is lesser than that, then probably it can be diabetic ketoacidosis or euglycemic ketoacidosis. So you need to know this difference also. And again, high lactates here can be because of the perfusion
Diarrhea and
problem.
dehydration.
Yes, yes. So you need to supplement patient with the fluids. Probably here you might start with 0.45 DNS. Okay, again, if it is a uh, alcoholic ketoacidosis, how you will manage, or starvation ketoacidosis? Because sugars are low, you have to supplement them with both DNS, glucose containing DNS initial part if the patient is hypovolemic. But here the correct the chloride is already on a higher side, so initial point you can give 0.9 NS. But then starvation, you have to give D10 simultaneously, or uh, for resuscitation purpose DNS and insulin. And again, for alcohol, you have to add like alcoholic patients.
Thiamine.
Yes,
Thiamine.
yes. So 32-year-old known case of diabetic non-compliant to medications, recent history of grade 2 amputation, got admitted with 1 episode of vomiting, 2 episodes of GTCS, was brought in post-ictal state to ER. On admission, he is deep drowsy. E2 M4 V2, got intubated for airway protection, received Levipil 2 gram, and his BSL is 700 milligram per dl, urine ketones tracely positive. ABG is suggestive of pH 2.6, 7.26, PCO2 of 45, bicarb of 15, lactates 8, sodium 150, and potassium 5. What labs and investigations are needed, and how will you manage this case? So, what this case looks like, I mean, what is the provisional diagnosis from the history and ABG and labs?
HHS.
Yes.
HHS
HHS.
is the first possibility.
Okay. So what labs and investigations are needed, particularly for HSS? What we need to calculate?
Serum osmolarity.
Very good. Especially in young patients and particularly in children, because again the cerebral edema is very common if you drastically reduced blood sugar levels in these patients. So that's why, what is the infusion rate, insulin infusion rate in HHS?
The initial bolus of 1.5 units per kg, followed
No,
by
like from
0.1 unit.
British guidelines. Yes.
Point
Like
1.
normally we don't use that high even for decay.
0.5 unit per kg body weight.
Yes, half not 0.5, 0.05. For decay we use 0.1 unit per kg per hour.
Yeah, yeah.
So for HHS, half of that, because here there is a relative insulin deficiency and there is no insulin resistance also many a times. Here the acidosis can be because of the vomiting as well as the seizure episode. The high lactates can be because of that. It can be because of hypoperfusion. It can be because of seizures also. So many the differentiating between the feature between HHS and DKA is in
The
DKA there
high,
will be, yes, tell me.
very high level of sugar in HSS, like more
No,
than 350 milligram. It will be more than 400
no,
milligram per day.
in HHS it should be more than 600. For definition
600,
it is more than
more
600.
than 600.
For DKA more than
Ketone,
250.
ketones negative usually in HSS with a
Yeah,
very high
trace
sugar.
or because the insulin is still there, the only hyperglycemia part will be there because of insulin deficiency. But there is a relative insulin is still sufficient not to produce ketones. So ketones will be either trace or very less. And even the acidosis will not be that severe. pH most of the times is 7.3 and above, and bicarb will be more than 15 only.
Okay, in this case,
And one
we
more
will go
important,
to measure corrected sodium because sodium 150. If you measure corrected sodium will come 165. What
very
fluid will give?
corrected
Will
sodium.
give normal
Yes,
saline or
I will give a half normal saline. I can start with half
yes,
ml.
yes. Here, because um, the directly free water will not start because again the seizures and we don't know
Diabetic
about the CNS
hypotension.
status. But yes, 0.45 NS will be a better choice. And again, till the osmolarity gets corrected, we cannot use sodium. Later on, we can use sodium also as a marker. Like all in sodium should be less than 10 milliequivalents in a day. That should be the norm. Even the serum osmolarity drop, it should be 20 millimoles in a day. Uh, Otherwise, particularly when the patient is young, or maybe when the such a high HHS patient and patient is not decompensated, it means patient is having chronic osmolarity changes and his brain has got adopted. So you those patients will be more worrisome than patient who are presenting with the CNS manifestations, because CNS manifestation is happening means it's an acute one. So even your serum osmolarity you can bring down little faster, like hyponatremia. The chronic is more deadly if you bring the sugar and osmolarity down faster. So these are the management changes. And pertaining to this case, he had seizure and all. So what will you do? I mean, apart from your HHS management, uh, controlling sugar and sodium, and again you need to know the calculated osmolarity and all. So for particular pertaining to his CNS symptoms, because he had already 2 episodes of GTCS, what
Cerebral edema, I will keep in mind the cerebral edema, and I will, for completion, I will take a CT brain and rule out if there is cerebral edema and start on anti-edema measures.
Yes, yes. So it might be CD brain. See, even if patient is not presenting in as a seizures and only presenting with HHS with altered sensorium because of this osmotic changes, they might present as focal neurodeficiency. Even HHS can present as a focal neurodeficiency. So it's one of the differentials. It might be that patient, because these are dehydrated, there might be watershed in if patient is vomiting, BP is low, watershed infarcts, ischemic infarcts, or it might be commonest is in these cases might be because patient had seizure and all. Even dehydration leads to, I'll come to this. You if you consider you have done CT brain and this is the report. I mean imaging. So what is
There
this?
is there is a left middle. There is a bleed in the left side MCA territory in bleed with the surrounding edema.
Yes, and there is a overall cerebral edema also, flattening
Overall
of
cerebral
cerebral
edema. Yes.
And one more thing, is it in that area of MCA territory? It's not typical
It's a
distribution of
yes.
MCA.
Yes.
No, it's not particularly that typical MCA territory. And I don't know whether you can make out this what you call this area at palx cerebrae.
Delta.
Yes, that what delta in CT brain, if there is a thrombus, what you call it?
Empty delta sign.
Yes, empty delta sign. Because of the thrombus, there will be a hypoattenuating area. So the empty delta sign, and it's not typical MCA territory distribution. So this is sagittal sinus thrombosis.
Cortical venous thrombus.
Yes, it's also very common in these patients. That's why all
Because of dehydration.
DKHHS patients, we need to treat them with what? If CBST is there, DVT prophylaxis, we need to give them. And now, what is the treatment for this?
Anticoagulation.
Yes, but Clexane BD dose.
Yes.
Therapeutic dose. Yes. So, and again, anti-edema measures and all, because there is a cerebral edema.
So it's a venous bleed, ma'am. The
But again, yeah, this is the venous bleed. So, the next case is 45-year-old known case of diabetic, and again, hydration is very important. Because in CCS we have already covered, that's why I'm not going through to it. But in HHS, you need to make them positive by almost 6 liter in 12 hours. So you need to give at least that much of fluids, unless patient is having any severe cardiac problem or kidneys are shut down, CKD, oligouric. The next one is 45-year-old known diabetic hypertensive IHD post knee arthroscopy procedure under GA got admitted in ICU with shortness of breath. On arrival, he is febrile, 101 Fahrenheit, delirious but arousable, and a BP is 90 by 60, and he is tachycardic of 130 per minute heart rate. Saturation is 86% on room air, so started on O2 by mask, and his heart rate got increased further. ECG was done, labs fairly normal except hypercalcemia. And following is his chest X-ray and ECG. Comment on it and what will you do? So in this case, 45-year-old with comorbidities and underwent not so high risk surgery, just knee arthroscopy, but it was done under GA. And now he presented with shortness of breath. He is febrile. And BP is also low, tachycardic, and desaturated. So, can anybody give DDs for this scenario from the history?
Acute
Embolism.
arthritis with
Acute?
arthritis, septic arthritis with sepsis and
Fat embolism.
You can put sepsis as a differential.
ALI
True.
sepsis.
But particularly,
Fat embolism.
Always remember
Can be fat embolism.
all endocrinopathy cases, no? Sepsis is in differentials.
Respiration pneumonitis.
Yeah, whatever. I mean, see, sepsis is done. What are the other differentials? Fever, GA, patient under
Fat
GA.
embolism.
fat embolism, aspiration pneumonitis.
Malignant hyperthermia.
Hyperthermia.
Yes, malignant hyperthermia. It can be one of the DDs. If they have given CPK and all, then it becomes diagnostic. But hypercalcemia won't be there. What else? Like, what are the DDs for malignant hyperthermia? What can
Neuroleptic
in malignant.
Thyrotoxicosis.
Okay.
Thyrotoxicosis.
Yes, very good. Thyrotoxicosis. Many a times thyrotoxicosis in young people without known uh, hyperthyroidism underlying maybe they might be having, but they were not that symptomatic, so not evaluated, undergoes a minor procedure and post-operatively presents as a agitated state, delirious, fever. You have to suspect thyrotoxicosis. And in differentials, malignant hyperthermia, neurolep malignant, again you need to read it. There are differentials like in masseter in malignant hyperthermia, then neurolep malignant fasciculations will be there, serotonin syndrome. If
And
they,
temperature will be very high. Rigidity temperature more
yes,
than
yes,
101 degree.
yes. So this is the chest X-ray. What it shows? What is the diagnosis?
It's a
This can
kind
be
of
pulmonary
air-based.
edema secondary to arthroscopy, severe arthroscopy.
Not secondary to arthroscopy. It's thyroid storm. So there is a sympathetic hyperactivity stimulation in thyrotoxicosis because of the sympathetic overactivity. These are all the differentials of sympathetic overactivity: the tachycardia, hyperthermia, delirium. So all this is the sympathetic hyperactivity, and that is maybe causing severe vasoconstriction. Cardiac filling pressures have gone up, and patient landed into pulmonary edema. Again, this is the ECG. What is the ECG showing?
Atrial fibrillation.
Yes, very good. But you have to utter atrial fibrillation with fast ventricular rate. So again, patient not having underlying cardiac problem, first time presenting. So two more cases will finish it fast. Uh, can you hear me?
Yes, sir.
So again, the management will be here. Thyroid storm. Anybody can tell me management of thyroid storm quickly?
Cooling the patient.
First,
Or
hydrate the patient, maintain the vitals.
Please utter airway breathing circulation. Okay. If the patient is not holding airway, desaturating, delirious, aspirating. So airway breathing circulation. I'll take care of airway. If needed, I'll intubate if the GCS is low. Breathing circulation. We need to give these patients fluids because excess of sympathetic catecholamines and all, they will be like, even in differentials you can put in post surgery patient undiagnosed pheochromocytoma and all. Okay, so because of the catecholamine response, this excess of catecholamines, these patients will be hyperglycemic. This patient might be volume depleted, so you need to take care of that. uh, Anything else? Temperature we need to bring down, giving them PCM, external cooling measures.
Propanolol or
Propensate.
hydrocortisone.
Propanolol you should not utter. Again, propanolol you should not utter because many a times these patients are having may have cardiogenic shock. So pulmonary edema, cardiogenic shock. Again, they might decompensate with beta blockers. They might have this. It's better supplement them with vasopressors, preferably prenin because it has a lesser tachycardia effect. So airway breathing circulation in circulation fluids and pressors if needed, preferably prenin because it has less tachycardia effect. Beta blockers you can use if the heart rate is more than 150, 140, 150, severe diastolic dysfunction. Otherwise, first and foremost, very important treatment is your hydrocortisone. Hydrocortisone give 300 mg bolus, and then you can give 100 mg BD or TDS, and then important drug is anti-thyroid medications. Methimazole, propylthiouracil. In pregnant patient, propylthiouracil will be the choice. You need to know the side effects also. Then again in methimazole, you need like Lugol's iodine or saturated potassium solution, iodine solution. These things should be given 1 hour after giving methimazole. Don't give before, because iodine has both the effects. It causes suppression of the T3 T4 release, as well as it helps in the production, because triiodothyronine, tetraiodothyronine, it needs iodine for the production. So first, otherwise, if you'll give before, it will cause more release of T3 T4 and it will precipitate thyrotoxicosis. So give hydrocort, give methimazole. 1 hour after, give iodine. Control temperature, give fluids, pressors, and uh, then if heart rate is beyond 150 or so, beta blockers. So again, you need to know the differentials and all. A 38-year-old female P2L2, known case of rheumatoid arthritis, came to the hospital with increased generalized weakness, easy fatigability, weight gain, cold intolerance, and mood swings. She has developed neck swelling. Thyroid function test was ordered, and this is the, see here in the history itself, it is giving a clue what it can be.
Hypothyroidism, cold intolerance.
Yes, even see the easy fatigability and all will be there in with adrenal insufficiency also. But here particularly rheumatoid arthritis means she's autoimmune. She has some autoimmune disorder.
Hashimoto's.
Yes, very good. So even thyroid. Can you read this thyroid function report? So I've not written the normal values here, but T3, T4 are fairly okay.
TSH is high.
Yes, TSH is very high. So whenever the even the subclinical hypothyroidism, where the patient is not symptomatic and your TSH is beyond 20, you need to treat it. So here also we need treatment. And these anti-TPO antibodies, it indicates again the autoimmune cause for the hypothyroidism. So, a 32-year-old male, recent history of COX, got admitted with progressive fatigue, fever, hypotension, tachycardia, drowsiness with the following labs. So now history is very important. In previous case, rheumatoid arthritis was the flu and that symptoms of hypothyroidism. Now in this case, COX is the history with young patient, progressive fatigue, fever, hypotension, drowsiness. Again, the sodium is low, potassium high. There is some acidosis, probably NAGMA, normal adenine gap metabolic acidosis. Here, the serum osmolarity is low because of hyponatremia. Urinary sodium is less than 20. What it indicates? If serum osmolarity, urine osmolarity is also low, urinary sodium is less.
Hypotonic, hyponatremia.
Yes.
With RTA, renal tubular acidosis.
Hypovolemic hyponatremia.
Yes, yes. And what is the likely diagnosis here?
High hypovolemic serum osmolality is low, na ma'am. It should be high in hypovolemic.
No, serum osmolarity low, it's a true hyponatremia. But urine should be concentrated. Urine osmolarity could have been little higher. When there is a hypovolemia, urine osmolarity, because if kidneys are okay, they should concentrate urine because there is a water deficiency in the body. So kidneys try to conserve the water, and then urine become hyperosmolar when it is
So it could be
hypovolemic. So consider this. Sorry, this is like consider this as 300, 400, something like that. But urinary sodium less than 20 indicates kidneys are conserving sodium, means there is a hypovolemia. So from this history of coughs, fatigue, hypotension, nagma, what it indicates?
Acute adrenal crisis with
Yes,
hyponatremia.
yes, very good. And what is the management? Again, same, we have seen the case. Previous case also we have seen that hydrocortisone, 100 mg stat, 100 to 200 mg stat, and then 200 mg for next 2 to 3 days, and then you switch to oral. Same patient, the random cortisol levels were done. It was this is the last slide. The random cortisol was done. It was less than 0.2 microgram per dl. Normally serum cortisol levels, if more than 20 microgram per dl, it rules out adrenal insufficiency, except in critical illness corticosteroid deficiency. Because in critical illness everything is dynamic, the requirement is quite high, so this rule doesn't apply there in CRCI, critical illness related cortisol deficiency. In that it doesn't apply, but normally it should be, if it is more than 20 microgram per dl, it rules out your adrenal insufficiency. Here the random cortisol level is less than 0.2, it means there is a cortisol deficiency. After 250 mics of cosintropine, after 30 minutes, serum cortisol level is 0.22 mics per dl, and the serum ACTH is 742. Normal is 5 to 27. Here the serum ACTH is high. So anybody can interpret it. I have already told you about primary as well as versus secondary adrenal insufficiency.
So it's a
Primary
primary.
adrenal insufficiency.
Very good, primary. Why? Because differentiating feature here is primary versus secondary.
ACTH.
Yes, in primary ACTH will be high. Clinically there will be hyperpigmentation, and in lab wise there is a aldosterone deficiency also. That's why hyponatremia, hyperkalemia. So these are all features of primary adrenal insufficiency. Again, can anybody tell me role of synactin test in septic shock?
No role, no role.
No role for
Yes,
that.
there is no role, because again I have already told you, we cannot put the serum cortisol more than 20 normal in critical patients, because critically ill patients, they are at such high stress that they need very high level of cortisol, so we don't know that normal range. So what is the criteria in critical related cortisol deficiency? When you call it that your patient is not responding to synactin test, though we don't do it, it's if the serum cortisol less than 10 microgram per dl, and after synactin test, if it doesn't increase more than 9 microgram per dl, but anyways we don't, the sepsis, surveying sepsis guideline don't recommend this, so no need to remember all this. So I'll end this session. View in endocrine there are only 4-5 variations, and if you'll consider all the endocrine cases in terms of DDs, it is very important, because even adrenal insufficiency patient presents as acute abdomen, nausea, vomiting, abdominal pain. So even DK patients present as a nausea, vomiting, abdominal pain. Whenever such histories is there and the lab parameters are showing something, even in this thyrotoxicosis, differentials, malignant hyperthermia, this neurolep malignant syndrome and all. But again, hypercalcemia, because in thyrotoxicosis, in that storm, osteoclast activity will be very high, so patient have hypercalcemia. In hypothyroidism, there will be lipid profile deranged, hypercholesterolemia will be there, and even diastolic BP will be high in those patients. While your adrenal insufficiency and thyrotoxicosis. Both will present as a volume depleted state. So wide pulse pressure. They present like a distributive shock. So these small things, if you know from the history and labs, you can make out the diagnosis, because in tables you will not get this much time. I have taken this as a theory class, but it will be like just less than a minute time. Only 5-6 cases. Do it by heart, so you will score more in this. Okay, I'll stop this class.
Thanks, ma'am.
Thank you, ma'am, for this class. If any aspirants have any question, they may ask now.
Okay.
The MRI you have shown, can you explain? Here,
Is
why
it a
was
pituitary
See,
macroadenoma or
in exam they will not put MRI. This is actually T1 MRI T1 sequence, and there is a hyper intensity. In T2 there will be little hypo intense area with dropout effect. So just from the history you can make out there is some abnormal in sella turcica at the level of pituitary. Normally what happens in pregnancy, anyways, because of this lactotropic effect, lactotropes, the prolactin and all that pituitary gland needs to produce during pregnancy, they are already under stress because their demand is more, they need to function more. And in that case, pph and all is causing ischemia because the blood supply is getting hampered. The metabolic demand in the pregnancy from the pituitary is increased, and that's why many pregnant patients are hypothyroid, because anyways the pituitaries they are at stress, and because of this pph and all. So from the history, even if you will not make out, if you know this area is pituitary gland related, there is a pph history, and that patient is producing as uh, anterior pituitary hormone failure, maybe thyroid deficiency, maybe adrenal insufficiency, or maybe anterior pituitary gland hormone insufficiency, or posterior. Posterior is rare because again we know that anterior pituitary, the this hypophyseal stalk and all, there the blood pressure for this anterior pituitary is low pressure bed, and for posterior pituitary it's a high pressure bed. So that's why anterior pituitary is affected more. So no need to know about MRI except for ischemic infarcts. Otherwise, in exams they will not put MRI. But pituitary apoplexy might come as one of the table, one case in table.
Okay, ma'am. So it
Again,
was pituitary infarct.
lifelong hormonal replacement is the treatment, because pituitary gland gets necrosed. Apoplexy is necrosis.
Okay. Thanks.
Yeah, you need to supplement them with the steroid, thyroid hormones, FSH, LH hormone also. Even many and transpenoid. What is the management? Surgical management in such cases. If patient is getting like vision problem, visual disturbances, getting blind, so transpenoidal pituitary this tumor resection or this is needed, because many a times it's not just the pituitary. Sometimes there might be a growth because there is a extra demand on the pituitary. There will be some mass and growth. So in such cases, for necrosis only, you have to give hormonal replacement. And if there is some mass also, which is very common because of, it might happen because of increased demand during pregnancy, then in that case you need to resect it out.
So it was pituitary infarct.
It is a necrosed pituitary gland with a mass.
Okay, ma'am. Okay. Thanks, ma'am.
Again, for hyperthermia cases, you need to know the DDs of hypothermia and hyperthermia, because these are also quite common. Neurolip malignant serotonin syndrome. Now this thyrotoxicosis, you just make a list. Thyrotoxicosis storm, which are what are the common DRs? Pheochromocytoma, malignant hyperthermia. So I have particular mentioned GA. Then scoline, inhalational agent, even if the short GA, many times we use sevoflurane, desflurane. Even that can precipitate malignant hyperthermia. But again, the muscle rigidity and masseter spasm and all those are common in this. Okay. I think if no any further questions, then we'll end this session.